So good afternoon to everybody. I will be here to substitute the Professor Paolo De Tosa. He is busy in the Italian, our Italian Society meeting. And it's a great pleasure for me to introduce a pathologist, an expert in gynecopathology topic, Sabrina Croce, that work in Bordeaux. And it is a great pleasure to introduce her that talk about to mesenchymal tumor of gynecological tract and updated to this wide range of tumors that is in some point is a little bit different to the other soft and bone tumors that we have discussed in the other meetings and in the other webinars that we have done in the Selnet. So Sabrina, you can start.
Hi, good afternoon or good morning for the Latino American pathologists and oncologists and clinicians that are attending. And it is a pleasure and honor to be invited in this talk on mesenchymal tumors of the gynecologic tract. I can't switch. Okay, I apologize. I'm not able in this time to treat to explain all these entities, but just in this 1 hour, I will explain the concept of simplex and complex genomic sarcomas in GYN, and then the uterine leiomyosarcomas, distinct subtypes, how to make the diagnosis, the concept of STEM, muscle tumors within certain malignant potential, and then endometrial stromal sarcoma, low grade, high grade, the adenosarcoma, the rhabdomyosarcoma, in particular, the ISR1 associated in the uterus, uterine pecoma, utrosk, and we will explain briefly the galaxy of the tyrosine kinase translocation associated tumors, the ALK and TRAC call. No time to speak about RET, MAZE, FGFR. This marked deficient uterine sarcoma, and we will finish with undifferentiated uterine sarcoma that unfortunately still exists. So briefly, I believe in the concept of the GYN as well. Soft tissue sarcomas are divided based on the genomic, in complex genomic sarcomas, and the prototypical lesions are in GYN, leiomyosarcomas, undifferentiated uterine sarcoma. For this tumor, we don't know a driver event, molecularly speaking, and when we analyze this tumor by whole genome, by NGS mutation and rearrangement, we found no rearrangement of a bunch of rearrangement, but there are no driver event. And these tumors are characterized by a complex genomic profile, as you can see in this profile on CGH of a leiomyosarcoma. When we have to translate this genomic entity in the morphology, what we see at the slides, in general, these tumors are pleomorphic. And by pleomorphic, I mean a tumor showing a large variety of cells in shape and size. The cells are quite different between them. And the other side, there is a simplex, or I don't know what mean exactly simplex, but not so complex sarcomas. And one of these examples is tract sarcoma, where there is a driver event, where, for example, in a fusion between TRAC1 and TPN3. And this fusion is essential and necessary to provoke this oncogenesis. When we look at the CGH of these cases, they are flat or not so complex. And when these tumors are under microscope, what we see, the translation of this genomic pattern is a uniform appearance. I mean, the cells are quite similar between them in contrast to pleomorphic type. Now, moving to the smooth muscle tumors and malignant part of leiomyosarcoma. And I try to be more, practical and to relate, to explain my practical activity. So first case was a 71-year-old woman presenting with 27 centimeters large mass in the corp of the uterus. The MRI was suspicion and the tumor grew rapidly, so no good. At the macroscopy, as you can see, there is multiple coalescent masses here with pushing border and with necrosis. Again, no good. And then we look at the slides in microscopy, we see the spindle cells, we also say cigar-shaped cells, not really similar to a cigar, but fusiform, elongated, with a lot of atypia. And we counted 28 mitosis by 10 high power field and translate in millimeter square 11.7 mitosis by millimeter square. This was a heterogeneous pleomorphic tumor. Again, an architecture, the cells are arranged on long, disorganized fascicles, and we see tumor cell necrosis. And at the immunohistochemistry, the tumor expressed caldesmon and desmin in heterogeneous manner. ERPR was diffuse and ALK was negative. Personally, I always perform ALK in a smooth muscle tumor in the uterus because I had some surprise. So the retained diagnosis is a leiomyosarcoma, spindle cell leiomyosarcoma, stage 1B. Why? Because it was a smooth muscle tumor, spindle with atypia, with tumor cell necrosis, and more than 10 mitosis by 10 high power field, or 4 mitosis by millimeter square. At the follow-up, the patient had a recurrence 8 months later. She was treated by gentamicin, and she has a disease progression, and she died in December 2021 for disease. Now, the second case that illustrated differences in smooth muscle tumor in the uterus was a case that I had in the house, in my hospital, in October 2020. It was a 60-year-old woman presenting with 11 centimeter large mass in the uterus, as you can see here, with rapid growing. Again, pushing border, again, necrosis. And when we looked at this tumor under the microscope, we see a diffuse growth pattern with hyalinized fibrosis with a lot of angioinvasion, as you can see here, with round borders. And the cells, more than 50% of the cells were epithelioid. I mean, round cells with prominent nucleus, prominent nucleolus, and we counted 28 mitosis on 10 high power field. What about immunohistochemistry? Look at this immunohistochemistry. You see that caldesmon was positive, but in a heterogeneous manner, and desmin focally positive. The majority of the tumor was negative. The problem is, if you perform a biopsy, you risk to say that this tumor is not a smooth muscle tumor. So they were heterogeneous. Good point, we perform systematically the CD20, CD23, or we look for tertiary lymphoid structures, and this tumor had mature TLS. It would be good for therapeutic purposes, for immunotherapy. Not for leiomyosarcoma, but in every sarcoma we are doing systematically. At RCGH, the tumor was moderately complex, with a degree of the complexity of this genomic profile, as you can see by this CGH, where there are in 3/4 chromosomes, you can see many rearrangement alterations. The retained diagnosis is epithelioid leiomyosarcoma. And this is a GYN tumor, epithelioid, because more than 50% of the cells are epithelioid. And according to last 2020 WHO, one or more of the following morphologic criteria are sufficient in order to make the diagnosis of epithelioid leiomyosarcoma: atypia, diffuse, moderate to high-grade atypia, tumor cell necrosis, and at least 1.6 mitosis by millimeter square. I mean, 4 mitosis and 10 high power. We had 28 mitosis, 11.7 mitosis by millimeter square. We have atypia, so this is an epithelial leiomyosarcoma. And in October 2022, the patient is alive with disease, with multivisceral metastasis. And now the third case is illustrating large spectrum of leiomyosarcoma. Is a 70-year-old woman presenting with total hysterectomy for multiple leiomyomas. One leiomyoma was subserosal, pediculated, and she underwent hysterectomy by morcellation. So on microscopy, the architecture was myxoid. There is a myxoid background. The tumor border were not accessible, which what's a pity, because it's the most important diagnostic criteria for myxoid smooth muscle tumor of the uterus. The vessels were prominent, and the cells were spindle fibroblastic with a lot of atypia. And we counted 1 mitosis, less than 0.4 mitosis by millimeter square. At immunohistochemistry, we performed a large spectrum immunohistochemistry, and the tumor was strongly diffusely positive for desmin, focal for caldesmon. Look at this, CD10 was diffusely positive for, so is this a smooth muscle tumor myxoid or fibromyxoid tumor as endometrial stromal sarcoma? ERPR were diffusely positive, ALK negative. Pay attention, keratins and CD10 may be positive in myxoid stump leiomyosarcomas. At this time, in 2017, I made the diagnosis at least myxoid stump. Myxoid leiomyosarcoma is something very aggressive, so I was very concerned. I don't have had a lot of material in order to decide. So I say stump myxoid, the patient has to be followed. I was very, very worried. Sometimes the pathology is the risk of life. So at follow-up, 3 years later, the patient had the recurrence. It was at 18 centimeter large mass in the pelvis. Again, the same morphology with 2 mitoses this time, maybe more atypical and more cellular. At immunohistochemistry, desmin was diffusely positive, again, ALK negative. And according to the criteria of the WHO, with 2 mitoses infiltrating tumor borders, because the tumor was infiltrating in the adjacent organs, this is a myxoid leiomyosarcoma. So the retained diagnosis is uterine myxoid leiomyosarcoma for the first tumor in 2017 with pelvic recurrence. So molecular data. In 2017, I did not have in my lab RNA sequencing. So I performed in 2020, no fusion was detected. And why I needed RNA sequencing? In order to exclude a B-core rearranged or B-core with internal tandem duplication sarcoma. And also because near 50% of myxoid leiomyosarcoma harbor PLAG1 fusion, but no fusion was detected. And when we look at the CGH, you see the first tumor, the uterine tumor, and now the pelvic recurrence. And you can see that there is a quite complex genomic profile. And we see the same alteration between the first and the second tumor, and more genomic events in the recurrence. So this is, sorry, myxoid leiomyosarcoma. These 3 cases allow us to explain the differences, sorry. Oh, sorry. The 3 different histotypes: the spindle, the epithelioid, and the myxoid leiomyosarcoma. Quite different, with different diagnostic criteria. Sorry. How we make the diagnosis? We look at the objective 10, and we look for, in order to assess atypia. And then we count the mitosis of the objective 40, and we report by millimeter square. And then the third element is the presence of tumor cell necrosis. But the most 2 reliable items are atypia and mitosis, because tumor cell necrosis assessment could be very difficult. In fact, in a paper reported by Diana Lim and Esther Oliva in 2013, they observe a low inter-observer agreement about tumor cell necrosis. So atypia and mitosis are more reliable. Just to summarize, when you have a spindle high-grade malignant mesenchymal tumor of the uterus, you perform smooth muscle markers and also ALK, if ALK negative, and at least 1 smooth muscle marker, you can call it spindle leiomyosarcoma. If you have 3 out of 3 criteria is better, of 2 out of 3 worrisome morphologic criteria, atypia, tumor cell necrosis, and 4 mitosis by millimeter square. If you have only 1 out of 3 criteria, you can call it spindle stump. For epithelioid, I cite now the classification of the last 2020 WHO. And then the next slide, I will explain the new proposal classification. Epithelioid leiomyosarcoma, when you have 1 or more of these criteria, diffuse atypia, tumor cell necrosis and at least 1.6 mitosis by millimeter square. I mean, 4 mitosis by 10 high power phi. And epithelial stump if you have more than 0.8 and less than 1.6 mitosis by millimeter square. And for that, the group of Brigham proposed new criteria. And the myxoid. You call it myxoid leiomyosarcoma, and for me is one of the most difficult diagnoses to make. One or more of these criteria. First of all, the infiltrative borders and more reliable. And then atypia, tumor cell necrosis. And when you have more than 1 mitosis and 10 high power, more than 0.4 mitosis by millimeter square. And myxoid stump if you have 1 mitosis without any other elements. Just to cite, uterine sarcomas account for 8% of uterine corpus cancer, and uterine leiomyosarcoma account for 63% of uterine sarcomas. They have a poor prognosis, 5 years, overall 5 years, survival up to 25% all stages, up to 47% stage 1, 2, I mean, limited to the corpus of the uterus. We know that epithelioid and myxoid leiomyosarcomas are more aggressive than spindle, and epithelioid and myxoid are oftentimes less mitotically active than spindle. And for this reason, the mitotic cutoff is lower than spindle. For myxoid leiomyosarcoma, the borders are the most important diagnostic criteria. So this is important for our pathologists to sampling the specimen. Just to remember, by definition, according to these criteria, uterine leiomyosarcoma is high grade by definition. This does not mean that low grade does not exist, but according to this classification, low grade uterine leiomyosarcomas is missed, could be a stump. There is study going on in order to assess low grade leiomyosarcoma, but it's different from soft tissue. Just to remember, epithelial leiomyosarcoma is rare, 7% of uterine leiomyosarcoma, but is more aggressive than spindle leiomyosarcoma. Remember, the present you need the 50% of the volume of the tumor in order to call it epithelioid smooth muscle tumor. The cells are polygonal, round, you have atypia, and not a lot of mitosis. In my case, it was mitotically rich. You have a diffuse growth pattern, thick vessels. And remember, smooth muscle marker can be weak and focal, and keratin and AMA can be positive, could be tricky for pathologists. This is the new algorithm proposed by the group of Brigham when you have a uterine epithelioid smooth muscle neoplasm. You have to check, do you have a nuclear atypia? Do you have 1.6 mitosis by millimeter square? Do you have a tumor cell necrosis? No. You don't stop at this. You have to go further. Do you have an infiltrative border in your tumor, or a typical mitosis, or tumor size at least 5 centimeters, or most important, lymphovascular invasion, angio invasion? If no, you can call it epithelioid leiomyoma. If yes, this is an epithelioid stump. If you have only one feature of these first 3, nuclear atypia, mitosis, 1.6 mitosis by millimeter square, tumor cell necrosis, you can call it epithelioid stump. If you have 2 or 3 features, you can call it epithelioid leiomyosarcomas. So this is a proposal and is changing. I personally follow this classification. Just to remember, in a paper published by the group of Sarah Chang some years ago, 35% of epithelioid leiomyosarcoma harbors a rearrangement involving a progesterone receptor. This was the morphology of the case with the rearrangement. Remember again, desmin could be diffuse or focal, and ERPR could be diffusely positive. Myxoid, again, the presence of myxoid pattern and background important. And when you have this, you have to pay attention because the diagnostic criteria are more stringent. So more than 1 mitosis or atypia, or with the most important infiltrating border, and you make the diagnosis of myxoid leiomyosarcoma. This is a nice paper relating some cases, less than 10 cases, because it's rare, myxoid leiomyosarcoma, studying the analysis, molecular analysis, and they found a low mutational burden. This is not new. We know that in leiomyosarcoma, but a copy number variation high. Again, this was studied first in the spindle cell, but we didn't know a lot about myxoid. This study was concentrated in particular myxoid. TP53 and CDKN2A P16 alteration were absent except one case. So it's strange in that this little series of myxoid leiomyosarcoma, P53 was not involved in the oncogenesis. By the way, BCOR in half of the cases, near half of the cases, showed internal tandem duplications, but outside the exon 15, though the signification was unknown, and without overexpression of BCOR. And again, absence of driver event. This is a leiomyosarcoma. Again, the group of Sarah Chang published some years ago the presence of PLAG1 fusion in 27% of the leiomyosarcoma with myxoid appearance. We know that maybe nowadays we can say 50%. So I regularly perform a check myxoid leiomyosarcoma in RNA sequencing in order to highlight this PLAG1 fusion. And PLAG1 fused sarcomas had PLAG1 nuclear staining, but is not reliable with antibody because it was positive in this series, also in non-rearranged tumor. Again, desmin is most reliable than caldesmon because it's oftentimes more expressed than caldesmon in myxoid lesions. And it helpful the differential diagnosis with the BCOR endometrial stroma sarcoma. Actually, it could be very difficult to make the diagnosis morphologically and immunohistochemistry between myxoid leiomyosarcoma and BCOR high-grade endometrial stroma sarcoma with myxoid appearance. And for that, RNA sequencing is very important. Now, STUMP. STUMP is smooth muscle tumors within certain malignant potential and is defined according to last 2020 WHO as a tumor that have morphological features that exceed the morphological features described in leiomyoma or in subtypes. But these worrisome features are not sufficient to call it leiomyosarcoma. In general, this evolves in malignant fashion only in a minority of cases. Actually, we call it in spindle smooth muscle tumor, STUM, when we have 1 out of 3 criteria. Or tumor cell necrosis alone, or I am that about tumor cell necrosis. I'm not sure this is ischemic or tumor cell necrosis, so you can call it STUMP. Or atypia alone, or when you have at least 15 mitosis without other elements, on more recently added in the criteria, the presence of atypical mitosis associated with atypia. Epithelial stump, the criteria are stringent. According to that 2020 WHO, what you are not able to call it epithelial leiomyoma or epithelial leiomyosarcoma is epithelial stump. Okay, just remember, I'm personally following the criteria proposed by group the Brigham to call it STUMP when you have additional morphologic criteria or only 1 features, and we explained before. Again, myxoid stump, I'm always very worried and with myxoid lesions, and actually is by exclusion, not myxoid leiomyoma, not myxoid leiomyosarcoma, and actually have 1 mitosis, just 1. 2 mitosis is sarcoma, so it could be very stressful for the pathologist to make this diagnosis. Now, moving to the 4th case. I had recently this case is a 63 years old woman presenting with vaginal bleeding. Unfortunately, at MRI, she has already had the diagnosis langet bone localizations, and she underwent correcting. And this is the appearance of the lesion. On the top right, you have a spindle monomorph appearance. On the left, you have a epithelioid lesions, quite atypical. So diffuse sheets of cells, low-grade areas with low mitotic count and some starburst appearance of endometrial stroma sarcoma, and high-grade area with epithelioid appearance, 17 mitosis, and Ki67 was limited in this area, 80%. So I went for a first random immunohistochemistry, smooth muscle marker negative, ERPR negative, cytokeratin negative. I use a lot B-core, cyclin D1 negative. I forgot to add P53 was wild type. And I signed out the cases as undifferentiated uterine sarcoma uniform type because I cannot call it low-grade endometrial stromal sarcoma. The result of RNA sequencing was the presence of JAS1 SUS12 fusion transcript, which is signed a low-grade endometrial stromal sarcoma. Strange. Let me see the clustering. And the clustering illustrated that the lesion was really in between a low-grade endometrial stromal sarcoma with JAS and high-grade group. Okay, and so I modified the diagnosis in they differentiated low-grade endometrial stromal sarcoma, and I think we have to remember this possibility. Not always a JAS SUS12 low-grade endometrial stromal sarcoma is still low grade. So as pathologists, we have still analyzed, well sampling, and be critical with our lesions. At follow-up, she's still alive with disease. And this case allows us to explain the group of endometrial stromal sarcoma. Remember, in this galaxy, we have endometrial stromal nodule is benign, like leiomyoma for the smooth muscle tumor. I don't have time to illustrate this. And then endometrial stromal sarcoma. In this group, we have low-grade endometrial stromal sarcoma and high-grade. Dutrosk, we will discuss about that, until some years ago was considered benign tumor. Now we are reviewing this entity and we can consider low-grade, kind of low-grade endometrial stromal sarcoma. And at the end of the spectrum, we have undifferentiated uterine sarcoma, very aggressive, with a kind of gradient of from on the left of the by benign tumor until the undifferentiated uterine sarcoma. CAT6 beta counts 11 sarcomas. I mean, I can put them in the group of low-grade endometrial stromal sarcoma. This is a new entity that has been recently described. I don't have time to illustrate it. So low-grade endometrial stromal sarcoma. First of all, you have a tumor resembling proliferative endometrium made of cells uniform, of course, because they are in the majority of the cases associated with a driver event. And you can see here the whirling of the cells around vasculature, which is characteristic, arteriolariform. This is infiltrating myometrium with a tongue-like associated or not with angioinvasion. And the infiltration of the myometrium is in general not destructive, but permeative. This is a microscopy of a case showing a lot of angioinvasion and infiltration of myometrium by tongue-like appearance. And this is a worm-like appearance, macroscopically speaking. And again, a case of angioinvasion. Macroscopically, again, importance of recognize these suspicious areas because you have to sampling them. For example, here you can suspect in this part just a benign tumor, just an endometrial stromal nodule. If you don't sampling this part, you will miss the diagnosis of a low-grade endometrial stromal sarcoma. And sometimes the infiltration could be more tricky. So again, importance of the macroscopy of the sampling. Immunophenotypically, in general, low-grade endometrial stromal sarcoma express CD10, and I prefer to use EFTM1 antibody. Desmin, caldesmon negative. But look at this. Desmin is not completely negative. And you can have some caldesmon positivity in the area of metaplasia, smooth muscle metaplasia. Again, in general, are ERPR positive and caldesmon negative. Keratin may be positive. Pay attention. I had some years ago a case with a endometrial stromal sarcoma invasive with the invasion of lymph nodes, and the keratin was strongly diffuse. So if you sign out a little busy, you can risk to call it invasion by a spindle cell carcinoma. The majority of low-grade endometrial stromal sarcoma are associated with fusion involving genes in the polycomb complex. The most important is JAS and then PC1, PHF1, which are genes which are very active in these polycomb repressive actions, and the translocation provoke the oncogenesis at transcriptional dysregulation. So the loss of control of DNA transcription, a much part of DNA could be transcribed, in particular oncogenes. Another alternative mechanism is always alterated histone acetylation. Now, high-grade endometrial stromal sarcoma. The first of them is sarcoma associated with the fusion YWHE. In general, the tumor is advanced stage at presentation, and you have in general diffuse myometrial infiltration in tongue-like, more often with angioinvasion, with more necrosis, with more mitosis. Pay attention, a component low grade could be associated. Again, importance of sampling and macroscopy. You can see here the vascular invasion. And when you look at the cells are uniform, but epithelial round, and there is a lot of mitosis and mytopia, and this is a high-grade sarcoma. Again, another particularity of this uniform appearance. I insist a lot of uniform appearance because it's a translation, a visual and morphological translation of the fusion, the underlying fusion. This tumor has a B-core diffusely positive. Pay attention, B-core immunostaining does not translate the presence of the B-core fusion or alteration. In general, they are cyclin D1 and B-core strongly diffused, the YWHE fused sarcomas, even if B-core is not fused, is not involved. When I say cyclin D1 positive, I mean like this, strongly diffusely positive in at least 70% of the cases, and B-core has to be the same, diffuse, not focal. Another good point is very useful because everybody has in his lab, P53 in general is wild type. And again, B-core positive immunohistochemistry does not mean that B-core is rearranged. In general, YE is epithelioid features is CD10 ERPR negative, but pay attention in spindle areas, and when associated with low grade could be still ERPR and CD10 positive. And this is the fish break apart, highlighting the separation of the probes for Y gene. Another important point, the P53 again is very useful in the diagnostic workflow. This was a paper that we published some years ago, and the majority of the cases associated with translocation, low-grade endometrial stromal sarcoma, high-grade endometrial stromal sarcoma, and the majority in tract sarcoma were P53 wild type. And this is the pattern of the expression of P53 wild type, as you can see in the figures A, B, and mutated when overexpressed or absent. In this series, I don't remember that there were cytoplasmic expression. If not, you can have also a P53 mutated that gave a cytoplasmic expression. On the contrary, the complex genomic sarcomas, leiomyosarcoma, had abnormal expression of P53 in majority of the cases. This is the mechanism, oncogenic mechanism, explaining the high-grade endometrial stromal sarcoma associated with YE, fused with NUT-M2, before called FAM22. And this YE belongs to the family of 1433 protein epsilon, which are involved in the control of the signal transduction, transcription, metabolism cells. In the same cells, YE and JAS are mutually exclusive, but they could coexist in the same tumor with different clone. And then B-core. I remember when it was described the first time in 2017, B-core disrupted the diagnostic paradigm of high-grade endometrial stromal sarcoma. B-core is named BCL6 transcriptional co-repression. Why they disrupted the paradigm? Because this tumor shows pushing infiltration or tongue-like infiltration. Push infiltration was never seen before in endometrial stromal sarcoma. You can have myxoid, round, and spindle cells. In general, is not observed in endometrial stromal sarcoma. And mangiopericytoma-like vasculature, again, new for endometrial stromal sarcoma. And the infiltration could be very tricky. Look at this case where the infiltration is in a manner of leiomyomatosis-like manner. It could be very, very tricky. And it could be destructive, as you can see here, where the tumor destroyed the myometrium wall. Could be like a multinodular pushing, like a multi-leiomyoma, like this is not at all a leiomyoma, very aggressive tumor. And this is a myxoid appearance with fibroblastic cells embedded in the myxoid stroma. In general, the mitotic count is high. We know now two variants. The variant associated with diffusion, BCOR with ZC3H7B genes, also called ROXAN. In general, these tumors are cyclin D1 for strongly diffuse. BCOR positive only in immunohistochemistry in 50% of the cases. CD10 ERPR could still be positive. Pay attention, Desmin could be focal, weak focal, but could be focal positive. And then the group of tumor with BCOR internal tandem duplication, exon 15, epithelial round cells, alternative with spindle cells and myxoid stroma. And CD10 could be variable positive, cyclin D1 positive, and BCOR more strongly immunohistochemistry, strongly positive. Again, BCOR negative does not exclude a BCOR fused sarcoma. Just to remember, because you know very well, soft tissue, MDM2 amplification was the hallmark of liposarcoma. For example, in retroperitoneal MDM2, we always perform MDM2 in order to diagnose a dedifferentiated liposarcoma. Remember, we have MDM2 amplification also in GYN. In BCOR, we arranged high-grade endometrial stroma sarcoma. In my experience, also in adenosarcoma. So in a retroperitoneal sarcoma in a woman, look or think about the present, the possibility of uterine endometrial stromal sarcoma. Another thing, BCOR-L1. BCOR-L1 is another genes that was described associated with high-grade endometrial stromal sarcoma. The problem is, could be partner with EPC1 and JAZ-F1, which are considered the, genomic hallmark of low-grade endometrial stromal sarcoma. And this nice paper demonstrates that the tumor harboring BCOR-L1 with JAZ APC1 are not low-grade endometrial stromal sarcoma, as you can see by this, this plot in clustering on methyloma, where the group of JAZ APC1 and BCOR-L1 and APC1 BCOR-L1 were clustered with high grade. The problem is, if you perform a FISH break apart for EPC1 and JAZ, the FISH is positive, so you call it low-grade endometrial stromal sarcoma, and this is not. In general, these tumors show some morphological features more similar to high-grade. But just this is important because if you use only FISH, be critical. Always, compare your genomic results with your morphology with suspicion. Another thing, and we come back to the arrow example. I explain an example that low-grade endometrial stromal sarcoma dedifferentiated, and actually was described some years ago with the group, the team of Sarah Chang, reporting, I think, 13 of cases of low-grade endometrial stromal sarcoma associated with an high-grade component. The majority of the cases, they had this uniform appearance. One case is pleomorphic. In general, epithelial round cells, as the case that I illustrated. So important is always sampling and look at the differentiation. When the tumors start to be less differentiated, when the tumors start to be less ovoid like endometrial in proliferative phase, when the tumors start to lose expression ERPR CD10, this is maybe a low-grade endometrial stromal sarcoma in the differentiation. And interestingly, this tumor did not harbor BCOR or YWHA fusion, but they still had JAZ-F1 and the other translocation associated with low-grade sarcoma. So remember, this is the synoptic table describing the differential characteristic: low grade, high grade with YE, high grade with BCOR. Same age. Remember, BCOR intended duplication may be in younger patient. And this is a molecular mechanism we explained. Again, the presence of round epithelioid cells could be in high-grade endometrial stromal sarcoma, YE, or BCOR, but BCOR more often spindle cells, or often myxo in background. And CD10 ERPR, strongly diffusely positive in low grade, cyclin D1 negative, is not proliferating tumor, and the other tumor, cyclin D1 and BCOR, variably expressed, in general, cyclin D1 strongly expressed. Again, P53 wild type, and the survival is not the same. Aggressive prognosis for high grade YE and BCOR. And for the differentiated, the survival was 42% died of disease. And these tumors start to lose expression ERPR, so you cannot treat anymore with hormonal therapy. Now moving to the fifth case, was a 71-year-old woman presented with 90 millimeter large polypouterine mass. At MRI, the extension was more than 50% of the myometrium wall. You can see here endometrial glands normal, and this proliferation looks like a rhabdomyosarcoma in the uterus. So again, I have a polypoid lesion, biphasic, with a benign epithelial component and a malignant component, which is a sarcomatous component. So first of all, in this case, in a menopausal woman, you have to exclude a carcinosarcoma. I remember carcinosarcoma is not a sarcoma, but it is the most important differential diagnosis with adenosarcoma. So sampling, you don't find any high-grade epithelial component. And then you look at the cells. This is a pleomorphic rhabdomyosarcoma, and this is dominant in the tumor, heterogeneous and pleomorphic. Look at the immunohistochemistry. The tumor have a rhabdomyoblastic expression with desmin and myogenin. So that my diagnosis was Mullerian adenosarcoma, because biphasic, with sarcomatous overgrowth and heterologous component, rhabdomyosarcoma pleomorphic type. Fortunately, patient died of disease 4 years later after diagnosis. And this case allow me to explain the adenosarcoma, which is defined as biphasic neoplasm composed of benign epithelial component and malignant stromal component. Remember, in order to assess the prognosis to treat the patient, you need to know, is this a low grade or a Mullerian adenosarcoma with sarcomatous overgrowth / high grade? The low grade adenosarcoma is a quite good prognosis, better prognosis. The high grade Mullerian adenosarcoma with sarcomatous overgrowth is a quite different disease, is very aggressive. This is appearance of adenosarcoma. The architecture is filled with leaf-like appearance. So you have here you have the glands, and you have a periductal stromal condensation and hypercellular stroma. And then again, rigid gland dilatation. Sometimes the diagnosis could be very difficult. The mitosis helps. The presence of the mitosis, of course, helps, but is a desirable criteria, is not anymore necessary. I mean, for low grade. For high grade, you have a bunch of mitosis. Remember, up to 50% of adenosarcoma can have, even low grade, an heterologous component of rhabdomyoblastic or cartilage. And importance, when you made the diagnosis of adenosarcoma, you have to precise if there is a sarcomatous overgrowth, which is defined by the presence of at least 25% of sarcomatous component without gland. And this, the component is in general a high grade, is very ugly, very pleomorphic or with high grade atypia, but could be also low grade, less frequently. Why is important to put in your sign out, in your report? Because this is an adverse prognostic factor. Actually, you recognize low risk adenosarcoma is a low grade Mullerian adenosarcoma. In your stromal component, you have a low grade endometrial stromal neoplasm, mild atypia, very well differentiated, CD10 positive, ERPR positive, P53 wild type. This is a low malignant potential. So you use the staging. Remember, it is not the same staging of endometrial stroma sarcoma and leiomyosarcoma, is in the depot infiltration of the myometrium. And then you look at the angioinvasions, are other prognostic factor. And then you look at high risk adenosarcoma. Is this a sarcomatous overgrowth defined by the presence of pure area of sarcoma without glands in at least 25% of the tumor, low grade or high grade? On the other hand, this high grade Mullerian adenosarcoma is not recognized universally by all the pathologists. Not all pathologists agree with that. You have a stromal component, not really sarcomatous overgrowth, but very atypical. You recognize the atypia of low power with p53 aberrant expression, ERPR low expression. This is differentiated. So in this case, the behavior is aggressive. Make attention in differential diagnosis. First of all, when I have an adenosarcoma under my microscope in a perimenopausal or postmenopausal woman, you have to exclude, first of all, a carcinosarcoma. So you have to look for high-grade carcinoma component like this, so sampling. And then pure rhabdomyosarcoma of the uterus, it does exist, but you have rhabdomyosarcoma only, and you have to sampling the specimen in toto is rare, is by exclusion diagnosis. And then remember, there is rare, but does exist, a collision tumor, the presence of low-grade endometrial carcinoma associated, grade 1-2, associated with adenosarcoma. Was nicely described by the group of Terry Longacre. It is possible to have this because carcinosarcoma have high-grade carcinoma component. So again, the importance of sampling. Just in the other part of adenosarcoma, when I have to make the diagnosis and I'm not sure between polyp complex or typical polyp in adenosarcoma is another field where I feel very stressed. How to make the diagnosis of low-grade adenosarcoma versus polyp. Sometimes there are merging lapping features. And I will cite a nice paper recently published by the group of Chapel Brigham. There were tested these atypical polyps. I'm not sure is low-grade adenosarcoma versus complex polyp. And they perform a molecular profiling, and they observe a biologic overlap between atypical polyps and low-grade adenosarcoma. Sometimes when we are in trouble with morphology, you are in trouble with molecular. In fact, up to 60% of atypical polyps harbor pathogenic mutation, but low-level amplification. And no Dicer1 mutation were detected in atypical polyps. The authors suggest to call it atypical uterine polyps because they merge morphologically, biologically low-grade adenosarcoma. But they lack the morphology and the biology of aggressive adenosarcoma. The good point is this tumor, the follow-up had a benign clinical course, and they suggest a conservative management, resampling and follow-up. And I always suggest to put together, to integrate your morphologic, immunohistochemical, molecular data with the clinic, with the MRI, ultrasonography, with the clinical history. If the patient is still young and she desire a fertility sparing therapy, and in the ultrasonography or MRI you don't have any residual disease with this atypical polyp, you can follow the patient, but it's important to put together all this data. Adenosarcoma Dicer1 mutation, as we discussed after with rhabdomyosarcoma. Dicer1 mutation are now essentially in our diagnosis. We know that between 20 and 42% of adenosarcoma harbor Dicer1 somatic mutation, and this in adenosarcoma pure or adenosarcoma associated with embryonal rhabdomyosarcoma component in low grade, as well as adenosarcoma with sarcomatous overgrowth. So sometimes we are struggling, we are in trouble in the differential diagnosis with adenosarcoma and embryonal rhabdomyosarcoma. And so we can figure out if Dicer1 is useful. Suppose we are in the cervix. If your Dicer1 is wild type, this is not an embryonal rhabdomyosarcoma, so it could be or a benign lesion. So again, go to your microscope and decide, or an adenosarcoma. If Dicer1 is mutated, You are not sure because it could be both adenosarcoma as well embryonal rhabdomyosarcoma. In the corpus, we know that up to 66.7% of the embryonal rhabdomyosarcoma of the uterine corpus harbor DICER1 mutation. So it's not useful because both entity could be mutated. Now moving to the case number 6, and a case I had some years ago, a child of 14 years, presenting a 10 centimeter large polypoid mass in the cervix protruding in the vagina. And I received the case in consulting as adenosarcoma with heterologous component, chondrosarcoma and embryonal rhabdomyosarcoma. So look at the slides. In the slides, you recognized immediately spindle ovoid, immature blue cells, and then immature cartilage, and then a cambium layer. I don't see a phyllid architecture. And then we characterize these cells and we see that they have a rhabdomyoblastic expression. This means MyoD1 myogenic. Pay attention, could be focal. MyoD1 more strong, and we perform molecular and we detected DICER1 mutation, activating mutation exon 26. We made the diagnosis of embryonal rhabdomyosarcoma of the cervix, DICER1 mutated, / I used both definition, DICER1 mutated associated sarcoma. And of course, we sent the patient to genetic counseling, and this patient had the DICER1 syndrome. So the embryonal rhabdomyosarcoma of the cervix is most frequent type of cervical sarcoma. It could be detected every age, of course, especially in young adult. Macroscopically, could be botryoid, grape-like, polypoid. And in a recent paper published by Kyle Devins and Esther Oliva, reporting 94 cases, and they had follow-up for 75, something like this. They recorded 11% died of the disease. So near 90% of 5 years overall survival rate. So it's not so good, not so bad as prognosis in the cervix. The characteristic in order to make the diagnosis, you can have hypocellular alternative with hypercellular foci, edematous stroma, a cambium layer, and a rhabdomyoblastic differentiation. You can have an immature cartilage in half of the cases. And the differential diagnosis, of course, as we said before, DICER1. We know that virtually all cervical embryonal rhabdomyosarcoma are DICER1 mutated. In the uterus is 66.7% according to the paper published last year by Jennifer Bennett. Adenosarcoma 42%. So in the cervix is wild type. This is probably not an embryonal rhabdomyosarcoma. If mutated, could be both. Interestingly, when you have a case, polyps in the cervix, you are not able to call it embryonal rhabdomyosarcoma. I would call it embryonal rhabdomyosarcoma, but myogenic is negative. I had recently a case like this. If you find a DICER1 mutation, you can favor this diagnosis, as was published by the group, the Glenn McCluggage. Of course, when you make the diagnosis of embryonal rhabdomyosarcoma, look for DICER1 mutation and look for DICER1 syndrome. So it's important, the genetic counseling. Again, 100% of cervical embryonal rhabdomyosarcoma mutated, but I don't know why the vaginal embryonal rhabdomyosarcoma are DICER1 wild type. Is near the same location, but they are wild type. They are also extremely rare. I will cite the nice paper published last year or 2 years ago by Felix Comos, studying the methyloma of the rhabdomyosarcoma. And you can see a distinct pattern of DNA methylation of the DICER1 mutated embryonal rhabdomyosarcoma, distinct from the other rhabdomyosarcoma, MyoD1 or alveolar, and distinct from the other embryonal rhabdomyosarcoma. Interestingly, all these cases were located in the genitourinary tract. And so recently, Glenn McCluggage and William Folks proposed the notion DICER1 associated sarcoma. Because remember, go for genetic counseling, especially in the young patient. Now our 7th slide. A 76-year-old woman presenting a large uterine mass with myometrial invasion. At the diagnosis, she has already lung and peritoneal localization metastasis. Look at the architecture. You see solid nest alveolar. This is, sorry, alveolar or pseudo-alveolar pattern, a kind of hemangiopericitoma-like vascularization. You can find also areas of sclerosing fibrosis. And the cells are large, polygonal cells with granular cytoplasm, eosinophilic or clear, with round nucleus and proeminent nucleolus. Sorry, the mitosis, I counted 11 mitosis on 50 high power field. This, the immunohistochemistry, the tumor was strongly HMB45 positive, cathepsin K positive, melan A heterogeneous, and the tumor expressed caldesmon. The retained diagnosis is PEComa, malignant PEComa. Why? Because of mitosis, atypia, size, angioinvasion, and because the patient had metastasis. And the follow-up, unfortunately, the patient died 3 months later, the diagnosis. So we know that there is two main categories of PEComa. In soft tissue as well in GYN. The conventional associated with TSC1 or 2 mutations and deletions in the context of the tuberous sclerosis complex, which could be syndromic or sporadic. In many cases, the p53 mutation has been recorded. And in immunohistochemistry, there is a double expression of myomelanocytic markers, HMB45, cathepsin, variable expression melan A, and caldesmon desmin will still be expressed. On the other hand, the group of the TF3 translocations, in general, there are no p53 mutation, and immunohistochemistry is strong and diffuse TF3 positivity, HMB45 and cathepsin positivity, and in general, as far as we know, smooth muscle markers are negative. Which are the clinical implications? The first group, the conventional, could be enrolled in TS2 mTOR pathways inhibitors, and the other in MET-TF3 pathways inhibitors. Here, the morphological appearance of the type 1 TSC1-2 mutation, the classic type of PEComa, which are used to recognize with larger cell, as we explained, and the melanocytic marker and smooth muscle marker positive, variable positive, and this is TF3 translocated PEComa, which is less frequent in my experience in GYN. And look at this, you have a kind of uniform, of course, you have two types of cells, but they are quite uniform because this is a translocation associated tumor. Look at the HMB45 strongly positive, cathepsin positive, and TF3 strongly diffuse positive. Pay attention, TF3 positivity could be very tricky. I always check the presence of this positivity by RNA sequencing, because sometimes could be not specific. In general, most markers are negative. And many papers have been published until now on PEComa and GYN. And this is diagnostic algorithm that Esther Oliva and Jennifer Bennett proposed. When you have a mesenchymal neoplasm in the uterus with myomelanocytic differentiation, so you perform molecular profiling and you see TSC alteration. This is a classic PEComa. If you find TF3 fusion, this is a TF3 translocation associated PEComa. And now the things are more complicated. If you don't find TSC, TF3 alteration, if you find some molecular alteration characteristic, oftentimes associated with leiomyosarcoma. I mean, TP53, retinoblastoma, ATERX alteration, for example. And you have an immunohistochemistry more than 50% of the tumor positive for HMB45 with a morphology suggesting a PEComa. In your sign-out, you can say, I favor a PEComa. Is epithelium, mixed epithelium in spindle neoplasm, suggesting a PEComa. But you can have also a case without alteration of PEComa, with alteration of leiomyosarcoma, and you have a HMB45 positivity, even less than 50%, with a morphology clonal, with an area suggesting a PEComa. You stay in a descriptive diagnosis, a sarcoma associated with a tumor suggesting a PEComa. And in fact, I had some cases where you have a kind of leiomyosarcoma, and in another part, in the heterogeneity of the tumor, you have an epithelioid lesion suggestive of PEComa. And I had some years later a metastasis from the PEComa part. It could be interesting also for therapy. Now moving to the eighth case, was a 69-year-old patient presenting a 10-centimeter large mass in the lateral wall of the uterus. You can see here the uterus, the corpus, the cervix, and the tumor exploding from the corpus of the uterus. The tumor was soft, yellow, necrotic. Look at the cells, quite, monomorphous, atypical. The cells are arranged in trabeculae and glands in tube. Looks like a sex cord appearance. Sometimes epithelioid with prominent nucleoli, rhabdoid. And I had the case in 2016, something like this. So you perform a large immuno, ERPR diffuse positive, CD10 diffuse positive, and desmin, keratin, EMA, calretinin, positive focal. This is a polyphenotypic tumor. Of course, I exclude as SMARCA4 deficient sarcoma. I perform CGH flat. Okay, but this is not a leiomyoma at all. So I went after studying for research these cases, and we highlight a fusion involving GREB1 and CTNNB1, which is a beta-catenin, and the tumor showed a nuclear beta-catenin. So how to put together all this data in 2016? I assigned out the cases as kind of bizarre utrosk, and I called my surgeon, please follow up this patient because I'm very worried. And in fact, 1 year later, she recurred in pelvis, and she had a pelvic extenteration. And unfortunately, she died of disease in 2018. So 2 years later, the diagnosis. Look at this the infiltration of endometrial stromal sarcoma manner. So, oh my God, I made the wrong diagnosis. This was endometrial stromal sarcoma, but is not, morphologically speaking, endometrial stromal sarcoma, but still uniform. Looks like a sex cord, but uniform tumor. And in fact, we published in some years later this first translocation of GREB1, and then the group of Chang and Lee collected more cases and found this GREB1 translocation. And these cases allow me to talk about utrosk. First utrosk described in 1966 was considered an indolent tumor. Clement and Scully described in 76. And then in 2017, Clement Kluge, Michel Moore collected more cases, and they observed that near 24% of the patient recurred, 9% of the patient died, 10 because one of these cases was in this series and died of disease. And the histology was not prognostic. They observed that the tumors that recur had necrosis and tumitosis, but no more. This is a nice paper collecting 26 cases by Emily Goebel and David Colling. And you can see the morphology and macroscopy. The tumor are quite nodular, multinodular. But when you look at the slides, the tumor is invasive in the majority of the cases. And this how looks like this tumor. You have some tubes. So remember Sertoli tumor in the ovary. You have a solid nest, epithelioid cell, trabeculae. Looks like a granulosa for the adult granulosa of these cells, or Leydig cell for these cells. So it's polyphenotypic and the histologic type tumor. Again, immunohistochemistry, you can have keratin, pay attention. You have a keratin strongly diffuse, invasive in the myometrium, you risk to call it carcinoma. Desmin and caldesmon heterogeneous, inhibiting and calretin are positive. In my experience, calretin is the best marker, sex cord for utrosk. And we tested FOXL2 is positive immunohistochemically in these tumors, but no FOXL2 or DICER1 mutation are present. And now we describe, and we know that there are two types of utrosk. First group, GREB1 rearranged. In general, are older patients, postmenopausal. The tumor is aggressive. You have round vesicular nuclei, epithelioid cells. Pay attention, inhibin calretin could be weak focal, could be negative. So do not exclude the diagnosis based on negativity of calretin. And then you have ESR1 rearranged tumor, younger patient, premenopausal, indolent tumor, with more sex cord-like appearance, Sertoli-like or granulosa-like appearance. In general, inhibin calretin more expressed, more differentiated. Again, appearance of GREB1. Now I call it GREB1 sarcoma, and I put in my discussion that this was a utrosk, but had more aggressive outcome. Beta-catenin could be positive if you have the translocation beta-catenin. And this, the appearance, more classic UTROSC of the UTROSC associated with ESR1 fusion. Of course, I have some other UTROSC without fusion, and the clustering are together with the UTROSC. Remember, this is a nice paper published by Jennifer Bennett and Resto Oliva, where they reported 3 cases of the UTROSC associated with ESR1 and COA2 fusion, so benign tumor, but that recurred. And the only element different from the tumors that did not recur is the rhabdoid appearance, but we need more experience. Now we move to tyrosine kinase associated tumor sarcomas, and we have the group of ALCOMA, inflammatory myofibroblastic tumor, and epithelioid inflammatory myofibroblastic sarcoma. The group of TRAC, the COL, and we don't have time to speak about MACE1 and other sarcoma. Look at these slides. This case was in our institution in 2006. 50-now-year-old woman. She had Morcelled hysterectomy, and this was the only part of the tumor where we can see the myometric wall. The tumor is ill-limited, not well-limited, pushing and infiltrating. And you can see the destruction of the myometric wall. The tumor is myxoid with 6 mitosis and 10 hypowerfield. There is necrosis and the spindle cell. Tumor was desmin positive, ERPR positive. In 2006, was diagnosed as myxoid leiomyosarcoma. Why not? Okay. 10 years later, I had this recurrence in the pelvic peritoneal recurrence. Tumor is more busy, more cellular, more inflammatory infiltration, more mitosis. And I don't know why I perform ALK. Actually, because in 2016, many inflammatory myofibroblastic tumors in the uterus were published. The ALK was positive, confirmed by the FISH. At this time, I performed the FISH for ALK. So this is in an inflammatory myofibroblastic tumor in 2006. We came back, we had retried on a slide, ALK was positive. And this is recurrence of the inflammatory myofibroblastic tumor. The good point, the patient was operated, treated with crizotinib, and she had a complete response and still alive in September 2022, alive without evidence of disease. So it's nice, nice diagnosis, useful for the patient. And now in uterine inflammatory myofibroblastic tumor, in general in young women, the mean age of 39, I had a lot of cases of inflammatory myofibroblastic tumor associated with pregnancy. And the tumor macroscopically could be gelatinous, as you can see, it was the same tumor I described, polypoid. And you can observe 3 types of architecture: myxoid, fascicular, hyalinized. The cells are spindle, could be like a small muscle tumor, fibroblastic, with a variable mitotic count. Lymphoplasmocytoid inflammatory infiltrate is present, but not always. Look at this tumor is myxoid. So differential diagnosis, myxoid leiomyosarcoma, fibromyxoid variant endometrial stroma sarcoma, B-core sarcoma, could have some phycite-like or cell culture-like appearance. And then you have the fascicular compact part. And for that, I always perform ALK in small muscle tumor of the uterus. Look at this case. I've been sent this case some years ago. And the pathologist said, this is a leiomyoma, is a caldesmon, desmin, ERPR. But look at this, it's strange. I cannot understand where the tumor started, where the tumor finished. Look at this, is fasciculated. It's not so appearance of inflammatory fibroblastic type so typical. And this is recurrent in the uterus. In fact, 6% of the stamp reported by the series of the Stanford, recently reported by the Elongaker, were inflammatory myofibroblastic tumor. So for that, I perform ALK systematically. So these are fibroblastic appearance, nodular fascite appearance, more tricky hyalinized appearance, again, mimicking a leiomyoma. How can assess the prognostic criteria? The presence of necrosis, tumor size 7 centimeters or 10 centimeters, high mitotic activity, moderate to severe atypical lymphovascular invasion. Remember, there is a kind of inflammatory myofibroblastic tumor malignant, call it epithelioid inflammatory myofibroblastic sarcoma, recently described in gyneco also, before was not described in gyneco, characterized by the fulminant clinical course, could be in pelvis, in peritoneum. I had a case some years ago, now 25-year-old woman in the uterus, she died in 3 months. Large nucleoli, large round nuclei. ALK is positive with perinuclear accentuation. It was reported associated with RAM-BP2, but not only. In immunohistochemistry, ALK diffusely positive and break apart was positive. And okay, now we don't have time to speak about inflammatory myofibroblastic tumor. Let me introduce the 10 and near the last case. It was a 29-year-old woman presenting with metrorrhagia. I had this case in 2020, and she had polyps in the cervix. This is the correcting. And the tumor showed a diffuse patternless architecture with uniform appearance. This is translocation associated sarcoma. You see this uniform pattern, spindle cells. There was 28 mitosis. All immunohistochemistry negative. First of all, you perform ERPR negative, smooth muscle marker negative. S100 negative is strange because in general it's positive. CD34 was heterogeneous, and PanTrack diffuse is strongly positive. And then we perform a share. At this time I used a share, and we highlight and track one fusion. So the retained diagnosis in track rearranged spindle cell sarcoma of the uterine cervix. At this time, 2020, no residual tumor, no other localization, and GYN and sarcoma tumor board decided for wait and watch follow-up. The patient recurred 1 year later, and because is young and she decided a fertility sparing treatment, she underwent conization, and after 24 months, she's alive without disease until now. Now, the track tumors, track uterine sarcoma seen a new emerging entity already integrating the last 2020 WHO. And until now, 46 track uterine sarcomas have been reported. The patient are quite young, mean age of 37 years, for 13 to 69. In the 80% of the cases, the tumors are localized in the cervix, less frequently in the corpus, stage 1 presentation. And because up to 20% recurred and gave metastasis and 14% died, should be regarded potentially malignant. This is the appearance. This is a fibrosarcoma-like appearance with patternless architecture, invasive destroying the cervix. Okay, uniform appearance. This is very important like concept. Mitosis could be 0 to 50. Atypia mild to moderate. Sometimes you can have epithelioids in plastic cells. Sometimes looks like an inflammatory myofibroblastic tumor with inflammatory infiltrate in appearance and cell culture appearance. So a differential diagnosis is inflammatory myofibroblastic tumor. PanTrack, in my experience, is strongly diffusely positive. All my cases are like this. And this is the commercially available PanTrack antibody list. The staining could be cytoplasmic only, perinuclear, cytoplasmic, or nuclear, and is, my experience, quite good. We know that as a screening tool, this PanTrack have some caveat, and because the cutoff positivity is fixed at 1%, for diagnostic purposes, this is good for diagnostic, but not good at all for diagnosis. This is not PD-L1, so we need to make the diagnosis. And for this reason, PanTrack in sarcomas has showed a sensitivity 80% and specificity 74%, because 3% of uterine liposarcomas can be positive, but more worrisome, because are really in differential diagnosis, 91% of high-grade endometrial stromal sarcoma can express PanTrack. So every PanTrack positivity has to be confirmed by molecular test. Just to cite the recent paper last year, Bridge from Graz, that tested PanTrack on 500 soft tissue sarcoma, and they observed that PanTrack is good track surrogate when you have a morphology suggesting on track mesenchymal lesion was in soft tissue, not in GYN, and when the immunohistochemistry is consistent with S100, CD34 positivity. And in our experience is quite good. Now, are we able to assess the prognostic factors for intrauterine sarcomas? We know in soft tissue sarcoma, TRAC3 fusion is bad prognostic factors. And recently, Costigan and the group of the Brigham collected the largest series of TRAC, 15 cases. And based on the 46 cases previously published, they assessed a high-risk tumor. What is an high-risk tumor? You need one of these worrisome morphologic features: mitotic index 8 mitosis, lymphovascular invasion, necrosis, and TRAC3 fusion. When you look in the Kaplan-Meier, the low risk is blue, has no recurrence and no death. The other group had recurrence and death, even if TRAC was not statistically significant, but there is a tendency. Why call it TRAC sarcoma and not just simply indifferentiated uterosarcoma? Because there is a clinical impact, as demonstrated in many tumors. And these tumors are targetable by TRAC inhibitors with quite good response reported 2 years ago in a cervical TRAC fusion sarcoma. And one of the last cases is a 42-year-old woman presented with 14 centimeter mass developed in rectovaginal septum. You can see here the corpus, the uterus, the cervix, the vagina, and this is the tumor. The tumor involved the paravaginal tissues, and she died unfortunately 3 months later. This is the tumor, and you have an area highly cellular, arranged in long fascicles, any area more myxoid with ovoid spindle cells. And again, a two area, you can see the nuclei are monotonous with 7 mitosis, CD34 strongly and diffuse positive. All other markers were negative. And the dual fusion fish highlight the present the COL1A1 PDGF beta fusion. And this is a myxoid variant of COL1A1 PDGF fusion associated sarcoma. This is a recent emerging entity in the GYN. Is rare, but I think is under-recognized. It's not yet included in the last WHO GYN. This fusion, you know, in soft tissue is associated with dermatofibrosarcoma protuberans, infantile fibroblastoma. For dermatofibrosarcoma cutaneous in soft tissue is malignant tumor, of course, with risk of recurrence and metastasis, but the 5-year survival rate is quite good, better than GYN rearranged COL1A PDGF beta tumor because they are very aggressive. This appearance, highly cellular blue tumor made of uniform ovoid blunt spindle-shaped nuclei. And immunohistochemistry all was negative. CD34 was strongly diffusely positive, but pay attention, areas of fibrosarcomatous transformation could be weak negative. And you can use a fish dual fusion or RNA sequencing in order to highlight the fusion. The good point, these tumors are enrolled in imatinib, and this is a case reported by in the group of Kudus, where COL1A1 PDGF beta were fused in uterine fibrosarcoma, and the tumor respond at the therapy for some months. This is the proposed algorithm for poorly differentiated spindle neoplasm. You have a poorly differentiated spindle neoplasm, performs muscle markers. You need at least one. Perform also ALK. If ALK, this inflammatory fibroblastic tumor, malignant one. If negative, this is a leiomyosarcoma. Smooth muscle marker negative or negative or focally positive. Perform cyclid-1. If positive, think about B-core fusion sarcoma. Smooth muscle marker negative, ERPR negative, pan-TRAC diffusely positive. Think about TRAC fusion, TRAC sarcoma. And ERPR negative, smooth muscle marker negative, pan-TRAC negative, CD34 positive. Think about COL1A1 PDGF beta fusion sarcoma. And last, a 23-year-old woman presenting with pelvic pain and already a pulmonary embolism. She had a large pelvic mass, an MRI, the mass originated from myometrium, and she underwent a cervical biopsy. You see, this is a normal endocervical gland displaced by the proliferation arranged in diffuse sheets of cells with a large epithelial rhabdoid appearance, 20 mitosis, rhabdoid appearance. And when you look at the immunohistochemistry, the tumor shows a loss of SMARCA4 antibody BRG1, loss of SMARCA2 antibody BRM, and P53 wild type. Pay attention, the loss of expression, the SMARCA4 is not only characteristic of this entity, you can find it also in undifferentiated, dedifferentiated carcinoma of the uterus. So this is most important differential diagnosis. The retained diagnosis is SMARCA4 deficient uterine sarcoma, P53 wild type, MMR intact. And when you look at CGH, this is flat with a lost 19 chromosome. If you look at the CGH in a context of smooth muscle tumor, you say, this is a leiomyoma, this is a benign tumor. The same CGH in the context of a rhabdoid tumor, this is a highly aggressive SMARCA4 deficient sarcoma. And unfortunately, she died 1 month after the diagnosis. The SMARCA4 deficient uterine sarcoma, an emerging entity, already included, I don't know, is included in the last 2020 WHO and GYN, is included in the, I think, in soft tissue. SMARCA4 is a part of Smith's chromatin remodel complex. And in this entity, there is a biallelic inactivation of SMARCA4. This is a sarcoma with simple genomic, as I shown by CGH. The patient are young, median age 42. The tumor advanced at the diagnosis. Oftentimes you have a cervical involvement, and it is a very aggressive disease with a survival less than 1 year. The tumor showed large epithelial rhabdoid cells with a lot of atypia, mitosis, prominent nucleoli, but it's not pleomorphic. I mean, all the cells are the same except the small cell component crushed and arranged in cords. And then, characteristically, the loss of expression SMARCA4, P53 wild type. But remember, SMARCA4 you also lost in the differentiated and differentiated carcinoma. So you have to put in differential diagnosis the age, the characteristic of the tumor, and the CGH. And finish with undifferentiated uterine sarcoma. In 2008, Curiara described this group, remember this group in pleomorphic type according to morphology and uniform type. And later on, with DNA and RNA sequencing from the group of uniform type, Chang and Lee described in 2012 the high-grade endometrial stromal sarcoma associated with YWHE. Oang and Sarah Chang in 2017 described high-grade associated BCOR. Sarah Chang in 2018 track. Our group called 181 2019. FGFR by Kelly Deveron 2021, and RET, and so Maze 1. So from the group on differentiated uterine sarcoma, but by RNA sequencing, more and more entities has been described. And in practical, when I have a tumor, pleomorphic or a uniform. In differential diagnosis, first of all, the most frequent, think about leiomyosarcoma, more uniform, high-grade endometrial stromal sarcoma. Don't forget to exclude a high-grade carcinoma and a carcinosarcoma, which are not sarcoma, but is the most important differential diagnosis. Mullerian adenosarcoma with sarcomatous overgrowth, a malignant pecoma, a pure rhabdomyosarcoma, but we have to include all the specimen. Of course, lymphoma, high-grade lymphoma, SMARCA4 deficient sarcoma, alveolar sarcoma in the uterus. I had some cases, was not able to talk about. Then tract sarcoma in the uniform type, COL1A1, inflammatory fibroblastic tumor, malignant one, solitary fibrous tumor. I had some cases, malignant one. And by exclusion, as in soft tissue, malignant peripheral nerve sheath tumor, melanoma, I missed some cases. And then after all molecular, all RNA sequencing, sometimes I'm not able to better diagnose this tumor and still call undifferentiated uterine sarcoma, pleomorphic or uniform. And I finish, just to remember, thank you, my city, Torino, the other city, Strasbourg and Bordeaux, where I'm working now. Thank you.
Thank you, Sabrina. It's an impressive presentation with a lot of information, really, really good. This webinar has been recorded, for you can see slowly with all the details in our web. Okay. Now we have a little time for a question. Alberto, you can.
Yeah, I have some questions that are right on the chat. to Heidi. We have a question about what would be the basic panel of immunohistochemistry to evaluate in epithelioid uterine and the spindle cell sarcoma at the beginning. That you have just explained in the last slide.
Yeah, maybe in the last. Sorry, maybe in the last, or maybe in the this one. No, this one. Yes, actually, you have a, first of all, do you think is more uniform or more complex, more uniform or more pleomorphic? Anyway, ERPR, just to see is differentiated or not. Smooth marker, why? Because leiomyosarcoma is the most frequent. You have to exclude. So you have to characterize desmin. I use also transgelling, caldesmon. Actually, I don't use a lot actin. I receive by consulting, but I also use with actin, a difference of solstitial sarcoma. And then also always ALK, just to exclude inflammatory fibroblastic tumor. And then just by exclusion, first smooth muscle tumor, no, is not. Looks like endometrial, low grade, high grade. So I use cyclin D1, which is mean not in just the cells that are in cycle, but cyclin D1 in high grade tumor is most consistent with high grade endometrial stromal sarcoma. And then when I feel that by exclusion is not smooth muscle, is not ERPR, the group of the galaxy of fibrosarcoma-like, so S100, CD34, Pantrac, STAT6. We don't have time to talk about solitary fibrous tumor, but it does exist. Don't forget it. This all.
Okay. So another question to Chelsea. In the context of high-grade endometrial stromal sarcoma, what is the role of NTRK immunohistochemical expression, and is this rearrangement targetable?
Yes. Alors, in our experience, working also with Raoul Perret, with François Leloirer, we use Pantrac, but we studied TRAC-C. In our experience, BCOR and high-grade endometrial stromal sarcoma express TRAC-C more than Pantrac. But Pantrac is targetable if you have, I forgot you put an interesting case, if you have the domain of tyrosine kinase. Actually, I had a case of leiomyosarcoma. TRAC was negative, and I sent for molecular because we are studying this entity, and we found a fusion involving TRAC. So this is TRAC, but morphologically speaking was not suggestive of TRAC. And when we analyze more deep, more carefully with our engineer, with my bioinformatician, we see that this fusion was not including the tyrosine kinase. So the expression of TRAC was lower, and immunohistochemistry was lower. So this was not driver. And this fusion was associated with a bunch of other fusion. So TRAC is targetable, yes, but in this context was not targetable. I hope to be clear.
Okay, so we have another question to Heidi. If you have a metastasis of epithelioid or rhabdoid sarcoma and a history of a uterine tumor, but we don't have the previous tissue, that is a classic example also in the bone pathologist, you don't have the documentation or the slides of the previous one, primary uterine tumor. How can orient the tumor to assure that the original diagnosis is a probable carcinosarcoma?
Okay, so I have a biopsy, is that?
Yeah, I think that you have a metastasis of epithelioid of rhabdoid sarcoma with an history of previous gynecological sarcoma without any documentation, without any
real
slides.
life.
Yeah, it's normal, yeah, day by day.
So rhabdoid in a biopsy, I have the history, I don't have the slides. Actually, in a biopsy, you have to suspect a carcinosarcoma, adenosarcoma. This is my real life. Oftentimes I say, okay, this is a postmenopausal woman, this is malignant, this is looks like a Mullerian sarcoma because I have a part of component of sarcoma, and I have a history of the uterus, you cannot exclude a carcinosarcoma. I still say the clinician, even the clinician often is not happy, because it's a carcinosarcoma, I change the chemo, okay. But on the slides, I cannot say it. In a biopsy, you cannot say oftentimes the component of carcinoma, the component adenosarcoma. I can just say, evoke, and I say first hypothesis, second hypothesis. And then I try to go further with molecular, with the clustering, the RNA sequencing, but is still at the beginning. So oftentimes you cannot solve the problem.
Yes, you say the biopsy is in the arm.
In the
arm.
In the arm. The biopsy in the arm. This is a metastasis from, it could be a metastasis from the from an adenosarcoma. It's rare. I had some metastases in soft tissue from leiomyosarcoma of the uterus. I had some cases.
Okay, Heidi, do you have some comments, Heidi, about your questions? No. And the last question is about the clone that you use about the ALK.
I use ALK1, but actually we have different clones, ALK1-4. I can actually I can send you by email, or you can email me, and I send my protocol of ALK. Because by heart.
Yeah, I know. It's not so easy to remember. Yeah. Okay. Heidi.
Hi, everybody. Well, my question was because we had a tumor that was in a patient, a postmenopausic patient with a tumor in the soft tissues of the arm. But he has that history of a uterine tumor. We didn't have anything, you know, as it is normally. It was from the uterus, the previous tumor. But we didn't have the slides or the tissue, nothing. So the thing that is because we see, one pathology sees the soft tissues and another one sees the gynecological tumors. So for me, it was a rhabdomyosarcoma, for me, the soft tissue in the arm. But it has the previous history of that tumor in the uterus. So how we use CD10, we use estrogenous receptor, and we didn't have anything else to do because it was
estrogen is negative in both. So estrogen is negative, ERPR are negative in both embryonal rhabdomyosarcoma of the uterus as well in soft tissue. So it's not useful.
With the myogenin, everything was like a rhabdo.
It's the same. Yes. Yeah. You cannot tell apart. You really need the first slides. Maybe could be interesting is available the study of DICER1. Because you can have some even older patient with embryonal rhabdomyosarcoma. It is embryonal or pleomorphic rhabdomyosarcoma. No, you cannot.
Yeah, we after like 6 months we had the slides from the uterus, but we didn't have the tissue, the blocks, the paraffin blocks. It was the same morphology, the same morphology
in the uterus.
Yeah.
But again, are you sure that you could able to exclude a carcinosarcoma? Because I had experience of a uterine carcinosarcoma that they gave distant metastasis only with rhabdomyosarcoma component.
Yeah. But we didn't have the paraffin blocks to perform anything. So it was very difficult, and the clinicians were very pushy, because they wanted to know what to do with the patient, of course. Yeah, so it was a very difficult case. And it was a great presentation. I am overwhelmed of information.
But maybe too much condensated to speed.
It's amazing the way that you did it. Really, congratulations.
Thank you.
Okay.
Okay.
Are there other questions for Sabrina? No.
Hi, good morning.
Hi.
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 Good morning. Thanks for the presentation. I have a question. PDL1 is alternative to study in the diagnosis of this patient, this kind of patients.
Sorry, what marker?
PDL1.
PDL1.
Yes.
As diagnostic marker. We start to use it, but in GYN, in cervical tumor. Actually, I don't use it. No, if I'm not obliged, I don't use it because I don't like the score of PDL1. Personally, think a pathology has better to do that. It's very useful for clinician, but you know, the positivity of the cutoff is very tricky. I'm most confident in TLS, tertiary lymphoid structures. We are seeing that and performing that every day in the context of the screening for STAR assays, for other assays. And actually, I think there are some tumors that are particular rich in TLS, and this could be very promising for treatment for even for sarcoma, which are not so sexy for immunotherapy. I think this could be a nice point for me, more than PDL1. But I don't have a lot of experience about it.
Thank you.
Other questions? So I have a very short question about what are the methods that use to evaluate the B-core fusion in high-grade endometrial stromal sarcoma. I mean, do you use at the beginning FISH analysis, or you prefer to NGS with a specific
RNA sequencing?
RNA sequencing directly when you have a cyclin D1 or B-core expression, or?
Actually, I perform RNA sequencing on all mesenchymal tumor of the uterus, but why?
Because you are very, very rich. Yes, of course.
No, because you need to enrich your cases in order to perform a clustering. You cannot use RNA sequencing only for tricky, difficult cases, because in order to, of course, for the fusions, even if there are some problems in order to detect intended RNA duplication, the B-core could be tricky. Not for RCR, but for wall RNA sequencing, there are some cases missing. But when you perform a clustering, you have to know that you need a lot of cases, and you need very easy, clear cases. I mean, leiomyoma or low-grade endometrial stromal sarcoma, very easy to detect. High-grade endometrial stromal sarcoma, because if you put in your clustering only difficult cases, your clustering is not reliable. So in order to be rentable and to help one patient, you need to spend for, I don't know, exactly 100 patients. This is not money that is waste. This is money that you invest. Yeah. It is important for me that the hospital people know this. Of course, it's expensive, but first of all, you will be able to collect of the data and to think about. And secondly, publish. Okay, publish is not the finality absolute, but is important, and then for the community. And for your hospital. And then in order to decide and to be able to detect the fusion, but also in the clustering, to better identify the tumor in your patient, you need, I don't know how many, but 100 easy tumors well detected in order to be in the comparison, you know?
I know. Okay. So if you don't have other question, you can finish. A special thanks to Sabrina for this.
Thank you for the invitation, and I am very happy. Merci. Ciao,
Grazie.
ciao. Grazie, ciao.
And okay.
Thank you so much, everyone. So I hope to see you very soon in the next pathology webinar from Selnet. Thank you.
Okay. Okay.
See you.
Have a
Thank
great
you.
day. Ciao.
Bye.
Ciao.
Bye.
Ciao.